Evaluation and management of Buerger's disease. Buerger's disease, also known as thromboangiitis obliterans, is a rare non-atherosclerotic segmental inflammatory vasculitis that affects small and medium-sized arteries, veins, and nerves, primarily in the extremities. It is strongly associated with tobacco use and often leads to ischemia, ulcerations, and gangrene. Here's a detailed overview. 1. Clinical presentation. Patients with Buerger's disease often present with the following symptoms: claudication, pain in the hands or feet, exacerbated by exercise and relieved by rest; ischemic ulcers, non-healing sores or ulcers, often on the fingers or toes; Raynaud's phenomenon, episodic pallor, cyanosis, and redness of the digits due to vascular spasm; rest pain, severe, persistent pain in the affected extremities, especially at night; gangrene, tissue death in advanced cases; superficial thrombophlebitis, painful, inflamed superficial veins. 2. Risk factors. Tobacco use, the single most significant risk factor. Age, commonly affects individuals aged 20 to 45. Sex, more prevalent in males, although the incidence in females is rising due to increased smoking. 3. Diagnostic workup. There is no specific test for Buerger's disease. Diagnosis is clinical and involves exclusion of other causes of vascular occlusion. History and physical examination. Focus on ischemic symptoms and tobacco use history. Doppler ultrasound identifies reduced blood flow in the affected vessels. Angiography, the gold standard for diagnosis, showing segmental occlusions or narrowing of arteries. Corkscrew collaterals, small, tortuous collateral vessels. Laboratory tests rule out autoimmune, hypercoagulable, and infectious causes of vasculitis, e.g. antiphospholipid syndrome, lupus, or syphilis. Inflammatory markers, CRP, ESR, are often normal. Allen's test evaluates collateral blood flow in the hands. Biopsy, rarely performed but can confirm the diagnosis by showing inflammation and thrombosis without atherosclerosis. Management. Management focuses on halting disease progression, relieving symptoms, and preventing complications. 1. Smoking cessation. Absolute cessation of all forms of tobacco is critical and the only effective intervention. Nicotine replacement therapy, NRT, is usually avoided as nicotine itself can exacerbate the condition. Behavioral therapy, counseling, and medications like varenicline or bupropion may be helpful. 2. Pharmacological therapy. Vasodilators, agents such as nifedipine or iloprost, prostacyclin analog, to improve blood flow and reduce ischemic symptoms. Antiplatelet agents, aspirin or clopidogrel, may reduce thrombotic risk. Anticoagulation, generally not recommended unless there is evidence of coexisting thrombophilia. Pain management, opioids or other analgesics may be required for severe ischemic pain. Prostanoids, e.g. iloprost, effective in reducing pain, healing ulcers, and preventing amputation. 3. Non-pharmacological measures. Wound care, essential for managing ischemic ulcers and preventing infection. Exercise, supervised graded exercise therapy can improve collateral circulation. Thermal protection, avoiding exposure to cold to prevent vasospasm. 4. Interventional and surgical options. Sympathectomy, surgical or chemical interruption of sympathetic nerves to reduce vasospasm and pain. Revascularization, often not feasible due to the segmental nature of the disease and poor distal targets. Amputation may be necessary in cases of severe non-salvageable ischemia or gangrene. 5. Experimental and adjunctive therapies. Stem cell therapy, investigational, but may promote angiogenesis and improve outcomes. Hyperbaric oxygen therapy may assist in wound healing and ischemic pain relief. Prognosis. Disease progression and outcomes are heavily dependent on smoking cessation. Without smoking cessation, patients often experience worsening ischemia, leading to recurrent ulcers, gangrene, and eventual amputation. Follow-up. Regular follow-up to monitor symptom progression, ensure smoking abstinence, and manage complications. Psychological support and counseling to address the challenges of smoking cessation and chronic disease management. Conclusion. Buerger's disease is a serious vascular condition that requires prompt recognition and aggressive management, with smoking cessation being the cornerstone of treatment. Multidisciplinary care, including vascular specialists, pain management teams, and wound care experts, is essential to optimize outcomes and maintain the patient's quality of life.